us today. Yeah, thank you very much for joining us today. We are having a webinar on Kaposi Sarcoma and we want to learn more. This is courtesy of Janssen Pharmaceuticals, who have been supporting us to get awareness on a number of cancers. And we are going to be having many more such webinars throughout the year. So I hope that we are going to learn a lot. And thank you very much again for joining us. KNCO is the National Body of Cancer Society Organizations. And we are committed to a unified approach to cancer epidemic. We have a membership of around 40 organizations working in different aspects of cancer control. Thank you very much. Back to you, Agnes.
Thank you so much, Charles, for the introduction. I believe I will not be able to allow everyone to introduce themselves, but we appreciate you so much for joining this webinar. And just to take you through or a light on the webinar or what is in our agenda for today. So basically, we are going to have one main key speaker who is going to take us through issues of epidemiology, signs and symptoms of Kaposi sarcoma, the risk factors and prevention, diagnosis, treatment, and general management. That is Dr. Matilda Ogondi from KNH. She's a consultant physician and clinical hemato-oncologist at the Kenyatta National Hospital. Then after that, maybe we'll have a short session on plenary, whereby we are going to have discussions and maybe some questions responded to and inputs. So kindly make sure that you're attentive and let's make this an interactive session. So karibu sana, Dr. Matilda. I believe you can just go on and do the presentation. Thank you.
Thank you very much for this invitation. I hope that you can hear me clearly.
Yes, we can.
Okay, great. Thanks for the opportunity. This is an important topic for us to discuss, especially here in Kenya and Sub-Saharan Africa. I'm going to have the KNH research team assist me with moving the slides, and feel free to drop in any questions or comments on the chat box, and we'll address those after the presentation. So the objectives for today are really to go through an overview of, first start with the definition. If we can move to the next slide, please. So the slides are not advancing. Okay, thank you. So we'll define what Kaposi sarcoma is. There are different types, so we'll look at that. Look a little bit into the clinical presentation, talk about investigations, and finally how to manage the patients. So that's going to be the overview for our discussion this afternoon. Next slide, please. So Kaposi sarcoma is actually credited to this physician who was a Hungarian dermatologist who described, in fact, what is written there is the title of the paper he wrote in 1872 of idiopathic multiple pigmented sarcoma of the skin. So this was seen really as a skin cancer. And at that time, they said it was idiopathic. And then in the 80s, we had an increase of observation of this condition, mostly in patients who were infected with HIV, mostly in men who had sex with men. And then increasingly, we've seen the spread and also the prevalence in the heterosexual HIV patients, or what we now call people living with HIV. And in 1994, there was the association of Kaposi's sarcoma with human herpes virus 8. In fact, it was called human herpes virus 8 because when they looked at skin biopsies, they were able to pick out or get this virus. And that's what was then later described as human herpes virus 8, and also known as the Kaposis sarcoma associated herpes virus. So basically, this is a vascular tumor. It can have different presentations, as we shall see, and it is caused by, so you can see in the description that Moritz Kaposi, because Kaposi sarcoma is named after him, had in 1872, has now moved from being idiopathic because now there is a clear association with human herpes virus 8. So as I said, this was discovered in 1994 and first associated with Kaposis sarcoma, but it has also been associated with other conditions. These are primary effusion lymphoma. So you have a patient who mainly presents with pleural effusions, and you can also have Castleman's disease, which is really different. You can have it occurring just where you have patients having lymphadenopathy, maybe in one area, you'd say that's unicentric, or having a generalized lymphadenopathy associated with hepatosplenomegaly. And these can also have been in a case where you have no association with the human herpes virus 8. So you can have a multicentric Castleman's that's in which the HHV8 is negative. But for this, what we're talking about is the one that is associated with human herpes virus 8. And then there's also an inflammatory sort of cytokine syndrome that's been described in HIV patients in the context of Kaposis sarcoma. And this has been associated with very high viral loads of the human herpes virus 8. Now, the important thing, and I didn't put the statistics there, is that as much as there's this association, this is a virus, like if you're to do as a check, a serology for patients who have or are positive for human herpes virus 8, and this has been done in different settings. And what has been found is a range between 25 all the way to the 70s. So but not all those patients get Kaposis sarcoma. So if I give you an example, there's one study that looked at, I think, Ethiopian refugees, and they looked at a good number of patients. And what they found is that the prevalence was in the high 50s, but less than 1% of patients who had HIV got Kaposis, and no patient who was HIV negative got Kaposis. So the fact that there is a high seroprevalence of this virus is not equivalent to patients later manifesting with Kaposis sarcoma. And this is because there are other factors which are related to the presentation or manifestation of Kaposis sarcoma, really around issues with regard to immunity. So, and that's why I've written there, host factors would influence the disease expression, as we shall see. Next slide, please. So as I mentioned earlier, there are different types of Kaposis sarcoma. I think what we have people who worked in HIV clinics or worked in the clinical space, you will be, I'm sure you have come across a patient who has most likely AIDS-related Kaposis sarcoma, but there are other types. And these other types are, like, you have the classic Kaposis sarcoma, which tends to be sporadic, and this occurs in males, mostly elderly, and actually it's, you know, characteristically in elderly males, and mostly in the distal extremities. Like the patients I've seen with these, usually old men, and then one patient who had involvement on the hand, and then a few others who had involvement of the lower limbs, and this is pretty much indolent. So that's the classic KS. Then you have the African endemic KS, which is similar to the classic KS. The only thing is that you can have visceral involvement. That means the patient may have lymphadenopathy, they may also have hepatosplenomegaly. And if this occurs in children, sometimes it can be aggressive. So whereas we talked about the classic being very indolent, in this one, you can have that variation. But by and large, most of the times you'll see still in males and then in the lower extremities. Then we have what is called iatrogenic KS. And this, most of the times you will see in patients who are post-transplant, mostly solid organ transplant. The ones I've seen are mainly patients who've had kidney transplant. So sometimes you get a consult from renal unit and they say this patient has this lesion which we are suspecting as KS, and this is a post-transplant patient. And in this patient, the reason is because post the transplant, the patient is put on immunosuppressive drugs so that they don't reject the kidney that has been donated to them. But this then predisposes the patient to get some of these opportunistic infections that can occur in that context of immunosuppression, and Kaposi sarcoma is one of them. So, and in this case, it's very simple, depending on the severity. If the expression of the disease is really mild, what you can do is just withdraw off the immunosuppressive agents, and they'll give an alternative, avoid things like steroids, and you can actually see regression of the disease. Now, the one that we commonly hear about, commonly see in the clinical space, and I'll also spend some time on it, is the AIDS-related Kaposis sarcoma, which can be localized or it can be disseminated. And this is one of the diseases, like if you look at the WHO classification and you're trying to see where this patient is based on their clinical presentation, this is what is called an AIDS-defining illness and an AIDS-defining, malignancy. So if you see a patient with this, automatically puts them on stage 4. So when you're seeing such a patient, then as a clinician, the thing you'll be asking yourself, is this patient compliant on their medication, or have they failed the regimen they are on, or are they, undiagnosed HIV? And so it's important to think about this thing. So again, these are the 4 types of Kaposi sarcoma that you would have. Let's move to the next slide, please. So when we look at the clinical presentation can be quite varied, but majority of the times you find that these patients present with cutaneous lesions. So again, just speaking to the importance of when we review these patients, having that thorough clinical examination, looking at their skin, and if you notice any lesions, how do these lesions present? Their presentation can be quite varied. I put that picture there. I don't know if it's clear to us, but the presentation can be, if you look above where those lesions are, there's some dark areas that are flat. So it can be patches, they can be nodules, such as are close to the ones which are ulcerated. There can be nodules which, where the skin cover is intact, or even ulcerated. And sometimes it can really be florid, depending on how the patient, how long the patient has had this. And, when it comes to describing, really, you can't stick to one thing, whether it's purplish, reddish, blue, black. What I tend to see is like on the skin in our patients, they will be hyperpigmented, either patches or plaques or nodular lesions. That's when you look at the skin, or ulcerated nodular lesions, or it can even be a huge nodular wound that is ulcerated. And it's important to check. So even if the patient just shows you the leg and says, this is where my problem is, you have to do like a head to toe, check the face, usually the nose, the ears, check the trunk, okay? Because sometimes you may have lesions there as well. So that is for the skin presentation. Now that is cutaneous, but then you can also have mucocutaneous. So look at this patient's conjunctiva, ask them to open their mouth, look at the hard palate. because sometimes you may have lesions there as well. And the hard palate, that is just what you can see. But if you think about it, as we shall see in the subsequent slide, the whole lining of the GI can be involved. So the other presentation that these patients can have is lymphadenopathy, and associated with that lymphedema. Sometimes you have these patients who come with this large, the leg is, they have a unilateral or bilateral swelling. If you check at the groin area, they have lymphadenopathy. If you're to describe the skin, it's not your, nice, smooth skin, it's woody hard. Sometimes it's all hyperpigmented. Sometimes it's the whole skin on the limb looks indurated. So it's also important to evaluate that as well. Let's go to the next slide, please. We've talked about the mucous membranes, and remembering at the back of our mind that sometimes these patients may have lesions in the GI tract, so they can have GI bleeding, whether occult or actually obvious bleeding. I've talked about lymphadenopathy. Pulmonary presentation can also occur, and sometimes this is confused with TB, especially in the patients who have associated HIV. And that's something common because we see the same thing when we're dealing with lymphoma patients. Any chronic cough is quickly labeled, rightly so, maybe because of our prevalence as TB, but I'm sure, as we're all aware, or when you look even at the algorithms, you are meant to investigate to the best of your ability what is causing this chronic cough, what is causing that chest X-ray to be like that. If it's not clear, asking for a CT or even referring the patient to the next level of management, especially where you don't have the obvious, sputum positive, maybe they have AFPs, or now the widespread gene expert. So these are the patients who you really want to have that additional diagnosis so that you make sure you're not missing out something else. So especially, we talk about the empiric clinical trial. Your patient is not improving 1 month down the line. Think about something else. Refer them to the next level of healthcare so that that TB can actually be worked up, because sometimes what is called TB ends up either being Kaposis or ends up being lung cancer or ends up being lymphoma. And the patients can also present with a pericardial effusion. We have a patient right now in the ward who has disseminated KS, but also has a pericardial effusion. Let's move on to the next slide, please. So just to emphasize what I have said, when we are looking at these patients, when we are examining them, at the back of our minds, especially for those patients with immunosuppressed or AIDS-related Kaposi sarcoma, which is what we will tend to see most of the time, they may have, next slide please, either limited or disseminated disease. And because of that aspect of disseminated disease, you want to make sure you do a thorough evaluation, thorough examination, and this really begins with your history taking. Do they have other symptoms like cough, shortness of breath? Do they have lower limb swelling if they've just shown you a lesion that is on their face? If we can move to the next slide, thank you. So let's move to the next slide. So just to emphasize again that a patient may have limited or disseminated disease. So what about diagnosis? Now, there are times, after you've seen a couple of patients, you can be like, this is KS. However, in oncology, even though it looks like it, what we want is really a biopsy, that we should commit not to begin a patient on chemotherapy, knowing the side effects of chemotherapy. We should always commit to have a histological diagnosis and not just a clinical impression. So what we would want is a biopsy. You want to biopsy the lesion that will give you the best yield. So, like the picture I had showed earlier about on the foot, if you were to pick the other thing is the site of the biopsy, because if you have many areas to choose from, you also want somewhere where it won't leave the patient with yet another wound. They already have a problem, so you don't want to add more problems. So you want somewhere where you can take a biopsy and it's sort of cosmetic also for the patient. But also, if you have those nodular ulcerated wounds, you really want to make sure you get a biopsy that will be representative, because sometimes you can have biopsies that are rightly so reported negative, but the reason is the sampling. So it's very important that when we're doing biopsies, we try and get the lesion that would be most representative and sort of avoid the lesions where there's a lot of ulceration, crusting, because most likely you're really not going to get a positive report from that, and you just get a report that tells you a lot of secondary inflammatory changes. Be aware that these lesions easily bleed. So, luckily enough, sometimes you're just doing a small punch biopsy and you can put it a quick stitch. Or if you're just, using a blade, still doing a reasonably small biopsy, but be aware of this, especially if the patient mostly presents with lymphadenopathy and you need to do a lymph node biopsy, or if it's a GI lesion and the patient is going to have a biopsy endoscopically. It's important to think about this at the back of our minds. So now in terms of diagnostics, for histology, we just don't stop at morphology. There is the additional sort of level of testing to make sure what you're seeing morphologically is in keeping with your diagnosis. So in this case, we would actually do a stain that checks for HHV8. There's the latency associated antigen, and in these patients who have the Kaposi sarcoma, it would be positive. You can also do PCRs. Let's move to the next. Of course, the PCR is not readily available. So I've put this slide there. A lot of the slides I'm going to, some of the slides I'll use the NCCN, because this is guidelines that are used commonly, but then also an important thing is like the NCCN has taken a step in terms of trying to harmonize their guidelines and see what parts of them are practical in the African setting. And they've done this with Kaposi sarcoma as well. I know there was some work in terms of doing the harmonization guidelines. I don't know if it's out yet in terms of publication. So as you can see, if we just go through it quickly, there's the essentials. So reviewing that biopsy that's been taken. If the biopsy is non-diagnostic and you're thinking this is KS, please biopsy the lesion again. Yeah. And we talked about the additional tests there. Then history, of course, we shouldn't be sending patients for tests if we haven't listened to them and examined them, because when we talked about what are these host factors that make the patient manifest, it's only by talking and examining the patient you'll find out, okay, these are patients maybe who's had a transplant, these are patients who's been on steroids, other than the skin lesion, the leg is also swollen. So, it gives you sort of a guide in terms of what to look for. Do they have shortness of breath and all those things? And then your basics are also important, looking at a complete blood count. Remember I said if they have GI bleeding, so you may have that these patients have anemia, and because they're having ongoing losses, the MCV may be low, pointing towards some iron deficiency. And they can also, especially where you're dealing with HIV or AIDS associated KS, they can have other OIs as well. We said this may be the initial presentation. So in that patient who's not had a HIV test, this is the opportunity to do it. And if it's positive, then doing a viral load as well as a CD4 count. And then there are other tests which may really come up based on the patient's presentation, because I would not say that every patient with KS, you send them for a CT chest. So it depends on the patient's symptoms. You've done an X-ray, it's showing significant maybe infiltration and effusion, So you want to, get more information about that. So in that patient, it is then prudent to do a CT of the chest. So it's also important to know that as much as all these tools are now readily available to us and patients can get them through NHIS, we should also be asking ourselves, why am I sending the patient for that test? In that patient who you're worried about GI lesions, you will send them for a scope. So we don't routinely scope every patient with KS, but if they have GI lesions, you're seeing they're getting a low HB, that NCV is low, you're trying to find out why, and they have disseminated cutaneous or significant cutaneous lesions, then you really want them to have an endoscopy and colonoscopy as well. Next slide, please. So now in terms of classifications, I look at two. This classification here is for classic KS. If you remember, we said classic KS is the one, classic and endemic are almost similar, mainly occurs in the lower extremities, mainly in old male patients. So the classification really or staging is based on the number of nodules which are involved, whereby from stage 1, where you have nodules confined to the lower extremities, to stage 4, where you're really having disseminated disease extending beyond the lower extremities. If we move on to the next slide, we look at the staging that we use for AIDS-associated Kaposi sarcoma, and this is what is commonly you will see. So the things to remember are 3 things. And we can move to the next slide, please. 3 things. One is the size, how these lesions on the skin. So that's why you want to do that thorough skin examination. How are they? Is it confined to the skin? Are the lymph nodes involved? Or is there extensive disease with ulceration? So T0 is confined, T1 is extensive disease, there's edema, there's GI involvement, other organs. And then the I is looking at the CD4 count. Remember, we are talking about the classification for the AIDS-associated Kaposi sarcoma. And the cutoffs really are, if your CD4 count is less than 150, then it's a poor risk. And then looking at systemic disease, is there any other OI or opportunistic infections? Do they have these symptoms such as a reduced performance status? We're familiar with the Kanofsky, although that one you need to sort of reference it, to know where exactly does this patient fall in, and that, if they have a poorer Kanofsky performance score, then that puts them in the poor risk status. Next slide, please. So we've talked about this. Sometimes the Kaposis may coexist, especially in the patients with the AIDS-associated Kaposis sarcoma. Next slide, please. So now, remember I said biopsy, biopsy, biopsy. Don't just rely on clinical presentation. If you see the image there on the African patient, that really looks like KS, but it's not. The biopsy showed bacillary angiomatosis, which is as a result of a gram-negative infection, so for which you'd be treating that patient with antibiotics and not chemotherapy. Yeah. And then the image that I have below, on the left, the gentleman whose eyes are covered is also another image of bacillary angiomatosis. And then the one I have on the extreme right on the leg, which is showing, you can see like the lesions are very linear. There's a phenomenon called Kobner phenomena, whereby like you have lesions following a certain line. And sometimes that happens with some malignancy and some skin conditions. So that patient has sporotrichosis, which is a fungal infection, in which case you've been giving them an antifungal. So not everything that looks like KS is KS. And that is why you always want a biopsy. Next slide, please. So when we look at the treatment, two things to consider. What is the context? We've talked about this over and over, and what is the extent of the disease, but then also what is the availability? Because yes, you may want to treat the patient, but what is available to you? Now, the goal of treatment is also important, and this is a common question you get from patients, especially when it comes to malignancies. You know, they ask, is this drug going to finish my disease? And the other, and is it going to cure me completely? But as we shall see, the goals of treatment for KS are really a bit different, because it's very rare, not it cannot occur, it's very rare for patients to get into remission. It can happen, but many times what you end up achieving is a very good response or stable disease. So it's very important for people to know that this is palliative treatment. And also it's important for you as a doctor to know that, because so that you're having a balance in terms of making sure you're not putting the patient through a lot of toxicity, given the chronic nature of this disease. So most of the times you want to reduce or reverse or alleviate the symptoms. Next slide, please. And I thought before I go into treatment, next slide, please. Again, referencing the NCCN, we are going to look at the response, because when you treat a patient, just like if you treat an infection, you want to know, is this drug working? So even if you get sick and you're given treatment, the goal is to feel better. So also when we are treating these patients, we want to have a standardized way we can communicate and say, has this patient achieved a complete response? That there is no detectable residual disease. You examine the skin, there is no edema, all that. At least, that is a sustained response for at least 4 weeks. So if there was any imaging that, you have resolution of that disease, and you talk about a partial response if you have a 50% reduction in whatever the disease is. And that's why it's important to sort of really know what is the disease at presentation and document it well, so that when the patient is getting treatment and they are being assessed, you're able to tell, are they improving or not? Sometimes the patients may have stable disease. That means there's no response either way. They're not getting worse, they're not getting better. It's just stable disease. And it's also not meeting criteria for progressive disease. That means you have more than 25% increment in terms of the lesion or the disease at presentation. Next slide, please. So just to let everyone know, you can access the NCCN guidelines, by the way. You don't need, if you can go back to the previous slide, you don't need to be a registered member. You just go in and log on. They'll ask you for some details, and so you can access all this, so that when you get a patient who has a malignancy, this is pretty much just for malignancies, whether it's hematological or solid tumors. So if you can go to the previous slide. So if you have thank you. If you have limited disease, PWH is person living with HIV. So there's a big move of patients, towards not being labeled by their disease and sort of giving them more humane descriptions. So you see that in many chronic illnesses, whether it's sickle cell or hemophilia and HIV as well. So an important thing where patients have limited disease is not to overlook the importance of starting antiretrovirals, because this can actually help in terms of resolution of the disease. At the beginning, we talked about the fact that this is related to immunosuppression. So if you improve this patient's immunity, then they are able to deal with the disease. And this is important because you may be at a center where you have access to ART, but you don't have access to chemotherapy or radiotherapy, which are the other options that are listed there. The topical agents that a patient can apply on the lesions. Sometimes you can inject small doses of chemotherapy into lesions. As expected, this will be the ones who have limited disease, because if a patient has disease, we're not going to inject chemotherapy into each and every of those lesions. If it's an isolated lesion, sometimes it may be that excision can be done. But remember, this is only with isolated lesions, or cryotherapy for limited disease, or radiotherapy, local radiotherapy. So that's very important to emphasize. Sometimes if the lesions are small, you started chemotherapy. Remember, antiretrovirals, we had one such patient who was reluctant to have chemotherapy, and when she was initiated on HEART, there was actually resolution, not a complete response, but at least a partial response in terms of her Kaposis sarcoma. Let's move on to the next slide, please, and let's move to the next one. This is just explaining what I have said about the local treatment, the radiotherapy, the topical applications that you can do surgery, intralesional chemotherapy, cryotherapy, or radiotherapy. Next slide, please. So of course, for the ones who have disseminated disease, then you're going to be doing systemic treatment because you really want to get your drug to all the sites of the disease. Next slide, please. Thank you. So for disseminated disease, again, is this patient able to get systemic chemotherapy? Because there are times where this patient has Kaposis sarcoma, we say it's a vascular tumor, they need chemotherapy, but are they stable enough to receive chemotherapy? So if a patient is eligible for chemotherapy, then you will give them that, assess the response as we have said. If they are not, as we have mentioned, do not overlook the importance of antiretroviral therapy. And sometimes it may be they have bulky disease on one area. It may be that you can offer localized radiotherapy to that particular disease site. Next slide, please. So this is really a summary of what is in the treatment box, if I would say. So first line, what is the ideal treatment? And we shall see some local data that looks at this. The ideal treatment is that these patients get liposomal, not the normal doxorubicin, liposomal doxorubicin, because this has a better side effect profile. The thing we're really worried about, especially in the HIV-related patients, is the cytopenias, low blood counts, low white cell counts. So this has a better side effect profile, but I'll warn you that even though it has a better side effect profile, you can't just give the patient and not monitor their counts, because sometimes they really still do get that, the cytopenias. So it's important to monitor the patient. Remember, because we are using doxorubicin, which is in the class of chemotherapeutic agents known as anthracyclines, which can cause side effects on the heart, anthracycline-related cardiomyopathy. It's important to do an echo for this patient. And recall, like I mentioned, we have a patient right now in KNH who has a pericardial effusion as part of his disseminated disease. We said sometimes there may be cardiac involvement as well. The other drug, especially for transplant-related patients, is sirolimus. And then the alternative good use for for AIDS-related patients, either your liposomal doxorubicin. If you don't have that, you can use paclitaxel. The thing to watch is the difference in the dosing, that if you choose to do every 2 weeks, you'll be giving them at 100 milligrams per meter squared. If you choose to do it every 3 weeks, you're going to be giving it to them at 1.5 milligrams per meter squared. Now, sometimes you give these patients this medication and they don't respond. Are there alternatives? So yes, there are drugs that you can use. The preferred regimen is pomalidomide. Pomalidomide is the sister to thalidomide, if I'll put it in a simple way. So it's what we call immunomodulators. So, in oncology world, you have your classic standard, chemotherapeutic agents, but you have all these newer agents that have come up that are not, their mechanism of action is different. So for pomalidomide, it's one of them. And you'll see there's pomalidomide in the middle column, you'll see there's lenalidomide in the last column, you'll see there is thalidomide. So really your immunomodulator, because remember we said this is something related to your immune system. So pomalidomide is an option. It's not yet readily available in many places, still high cost. But you have other options like bortezomib, gemcitabine. Remember that chemo you're going to be giving every 2 weeks. So it's very important to also look at your quality of life for the patient so that you're not causing them undue cytopenias without any significant benefits. Next slide. So looking at local data, I thought I'll just put this in there as a way of summarizing. We've talked about this, we've looked at this nice table that is recommended by the NCCN. In the harmonized guidelines, it's a bit different. But the studies which have been done locally, a lot has been done by the team at Eldoret, the AMPAC team. So the first study is a study that was published in 2004. The basis of this study was to see, because in Kenya, I think the first case of HIV was reported in 82. So they were looking before 83 and after 83. Was there a difference in terms of the Kaposi sarcoma? And they found, no, not really, because as much as maybe the numbers went up, we still had more male patients who were young. It was mostly cutaneous involvement. It was mostly the lower limb which was involved. Then Busahala et al., this was the Western Kenya group from MPRH. They looked at randomizing patients to get either gemcitabine or bleomycin, vincristine, which pretty much in most places is what patients get. However, there's a shift towards trying to give patients, where you're able the best available treatment. So either you're like
Hi, Doc.
Yes.
Sorry to interrupt you. Seems like we're going a little bit low on your volume.
Okay, all right. Can you hear me now?
Yes, we can totally hear you.
Thank you. I hope earlier on you were able to hear.
Yes, you are able to hear earlier on. It's just at that point you had seemed to be
the local data. Okay.
Yes. Okay. So
all right. Okay. So we go to the slide on local data. Next slide, please. Next slide, please. Okay, I'm seeing Jacqueline is saying at least you can hear you now. I hope you had me before.
We had you, but you're a bit faint.
Oh no, sorry. Okay.
Yeah,
I hope they were okay, fine. So this is the local data. I've talked about that, the fact that there was really not much of a difference in terms of the type of patients, and really pretty much this is a disease that mostly is in the male population, whether it is here or in the West. The age is maybe what is different in our population. As you look at all those studies and you look at the median age or the mean age in the last group, you have a median age of 37.2, and then you have mostly male presentation, and you can see, as I mentioned earlier, most of our patients are still getting bleomycin, vincristine, or an additional of adriamycin. Many people shy away from the adriamycin because of the associated cytopenias with it. If we can just move to the previous slide, I've seen a comment saying I was not clear on the management part. Yes. So if I can just take, because that's important. So if we can just move to the previous slide, I'll just, we're almost done anyway. So if we can move to the previous, thank you. Let's go to the previous one, the one for limited disease. I think it's before. Okay, before that, sorry. There, we can do that. So for those, sorry, who didn't hear me clearly, what we said is in patients who have limited disease, you have options for the limited disease where you can either use topical agents such as tretinoin or imiquimod, but this is for very limited disease. Majority of the times, especially for the AIDS-associated malignancies, Kaposis, you find patients who have disseminated disease. Radiotherapy is an option. This is something that's practical, that can be done, and dependent also on the involvement. So if you recall earlier, I said, you really want to know, am I dealing with limited disease or am I dealing with disseminated? Because it's going to have a guide on what you do in terms of the treatment. Sometimes if it's just small lesions and you can see they're small, less than 1 centimeter, you can count the number of patients who you see who have small lesions. So that if it's a small lesion, you can excise it. If it's, or you can inject chemotherapy to those lesions. Imagine if the lesions are all over the body, you can inject chemotherapy in all the lesions. So these are for very isolated lesions. And then we've also talked about cryotherapy. So if we can move on to the next slide, the one with the table. So this is for limited. So now we are going to go to disseminated disease. For disseminated disease, we've said you want the treatment that will go everywhere where the lesions are. No, previous slide. Yes, thank you. So we've said that the first line, so we are talking about what is the ideal, because there's ideal and then there's what we call in, real world, what's happening in the real world. As I say, vitu kwa ground. Saa zingine ni different. So ideal, what should you do? Preferred regimen for this patient is liposomal doxorubicin. I said it has a better side effect profile, but that shouldn't fool you not to monitor your patient's counts and check for cytopenias. When you give patients chemotherapy, when it comes to the sort of maximal effect of the chemotherapy and seeing that, it's really around your day 10 to 14. So you really want to be on the lookout, see the patient around that time point so that you're able to do your blood counts and support them accordingly, whether they need transfusion or whether they need a granulocyte colony stimulating factor. The alternative is to use paclitaxel. Sirolimus, we tend to use just in patients who are transplant patient. So sometimes you give these patients treatment, but they don't improve. We looked at the previous slide on the response. So if they don't improve, if you use liposomal doxorubicin, you can use paclitaxel. If you use paclitaxel, you can now move them to liposomal doxorubicin. So these are the other alternatives which are there. Pomalidomide, although I've said that is not readily available in the country, but if you source for it, you can actually get it. But other options are your chemos like gemcitabine or your other newer agents like bortezomib, and even your tyrosine kinase inhibitors, imatinib, that is used for patients who have CML. So if we can move to the next slide, then I just went through the local data, which was just sort of giving what our statistics are. That we mostly see male patients. Patients are mostly young, and majority of the patients are still getting either bleomycin vincristine or adriamycin bleomycin vincristine. Next slide. I thought I would just put in a slide on the immune reconstitution syndrome, IRIS, which, because we say if a patient is HIV positive, you can initiate them on HEART. And sometimes what this happens as the immune system is awakened, that these patients have a worsening of their clinical presentation. So that is called IRIS. There's a criteria that's been proposed where you have one major and one minor would, clinch sort of your diagnosis. That means the patient has new onset or signs of progression of their existing Kaposi sarcoma lesions, and then a minor is that, your viral load has gone down, you have a 1 log reduction, or you have a significant rise in your CD4 count. You should not stop the ARVs, support the patients, and ideally, if these patients are not on chemotherapy, you'd want to start them on chemotherapy. And really, you want to avoid steroids because steroids have been associated with the progression of Kaposi sarcoma. Next slide, which I think should be my last slide. So in summary, what have we talked about? That we have different types of Kaposi sarcoma. The most prevalent is the AIDS-associated Kaposi sarcoma. We talked about how to stage it, looking at the tumor, the CD4 count, and whether the patient has systemic symptoms. We've talked about the clinical presentation, either being limited or disseminated. We've emphasized the importance about biopsy. So biopsy, biopsy, biopsy. Don't assume it looks like KS, it is KS. Please do a biopsy. We've looked at the treatment options, whether it's limited disease or disseminated disease. And the most important thing is, when you're treating a patient, the patient comes in with their ideas, their expectations, and their concerns. There's an acronym that's used, ICE. So whatever disease you're treating, when you see a patient, they walk in with their ideas, myths, sometimes truths, sometimes what they've heard or read in social media. They have their concerns about their current illness and their expectation. And it's very clear to make it known to them that the expectation for this is if you're treated and it goes away completely, that's very good. But the expectation is really to control it. Sometimes that swollen leg may not go back to normal. But if the lesions can resolve, there's less lymphadenopathy, maybe an ulcerated wound, becomes smaller and, over time heals because now it's shrunken. So the goals of treatment have really to be very clear. Thank you so much for listening. And I hope that you were able to gain something out of this. And thank you for the organizers for inviting me to present. Thank you very much.
Thank you so much, Dr. Matilda. That was a very wonderful presentation, very straight to the point and very summarized nicely. I'm sure all of us here now know some of the key points on Kaposi sarcoma. So I'd like to pick a few questions from the chat box, Dr. Matilda, before you go. Then we can have you respond to them, and then I will end by 3 p.m. So the first question is, if a patient is on prolonged use of steroids for asthma, is there a risk for Kaposi sarcoma? And then the second one from Dr. Ruth Jaoga was a patient who has been on steroids and presents with pericarditis or pleural effusion. How would he be investigated to rule out Kaposi sarcoma? What other presentation can one expect? How would such a patient be treated if the HIV status is negative? So maybe you could respond to those two, then we can pick another two. Thank you.
Right. Okay, so what I'll try is sort of try and put them together. So I think there's one on the prolonged use of steroids. Yes, we've talked about steroids, any steroids, whether, because sometimes people think it's just because you're not taking the tablets. So even inhaled steroids, so it's any form of steroids are at risk of Kaposis sarcoma. But remember, we said there are many factors that go into a patient developing Kaposi sarcoma, because there was another question talking about, is the HHV virus detectable in KS? Yes. And actually, it's how did at the beginning, I went through the history that before this was described as something that was idiopathic, but in the 1994, when they looked at the biopsies, skin biopsies of patients with Kaposi sarcoma, they isolated this virus, and after that is what it was named human herpes virus 8. And is there associated with antiretroviral treatment? Yes, because we talked about iris in the last slide. Unfortunately, I don't treat children, so I'm not able to really give a comment on that. We've reviewed local data, so that answers the question of someone who had a question on local data of HIV treatment on the prevalence of KS. In fact, recently there's a paper I didn't include there. There's work that was published by the MTRH group, and what they found is that if, they did like a cost analysis and found it would be actually more cost effective for the government to work on ensuring our patients can get paclitaxel rather than the patients being on bleomycin and vincristine, because they would have better responses, you're able to control your disease earlier. So when you look at all those things together, there's one about expound more on the mucous membrane KS presentation on the hard palate. We say that can occur, and sometimes that can be associated with KS lesions in the rest of the GI as well. There was the question, if the patient has pericarditis or a pleural effusion, how would they be investigated? So we talked about biopsy. And these are the patients now in whom you need, like if it's a pleural effusion, the chest physicians or the interventional radiology team to help to do a pleural biopsy. So, and if because I'm seeing there they're saying if the patient is HIV negative. Remember, if a patient is HIV negative, you really need to make sure you're not, especially if they have disseminated disease, you're not missing out something else. They were not in immunosuppression because of being a transplant patient. The other thing we've mentioned is multicentric Castleman's that can sort of present the same way. How frequently do you find cases with Castleman's disease? It's reported in literature. I personally have not seen. I've seen a patient, patients with Castleman's and patients with KS separately. And that's why you really need that biopsy to help, because then they would do your special stains. The ones with Castleman's will tend not to have, because KS, we've said you have this cutaneous lesion, so they'll tend not to have that. And I see it's 1 minute to 3. So I've tried to go through most of the questions in the Q&A. Thank you.
Thank you so much, Dr. Matilda. I think actually you've tackled most of the questions. And since we had agreed to end at 3 p.m., I hope you have not closed out on anyone. You have been able to tackle every question. So thank you so much for everyone who has joined the webinar for today. I hope it has added your knowledge on Kaposi sarcoma. There's going to be more and more trainings or webinars. So make sure that you join. Also, I would request if maybe the participants can be forwarded the presentations just for their reference in future. So thank you so much, Dr. Matilda, and over to Charles, maybe for some closing remarks, and then we can end the webinar. Karibu, Charles.
Thank you very much, Agnes, and thank you very much, Dr. Matilda, for the very informative session. I don't have anything else to add other than to thank our participants for joining us, and to thank the KNH Bucket team for really taking us very well. Thank you very much, and have a good afternoon.
Have a good afternoon as well.
Thank you.
Bye. Bye-bye.